Hi, I'm Rachel Shelton. I'm a faculty member at Columbia School of Public Health, and I'm excited to talk to you today about an introduction to implementation science. So we're going to start off with just some of the initial framing about how the field developed. So what is implementation science? Why does it matter? You have probably heard a lot about it. It's grown hugely over the past 10 to 12 years. And particularly in the last couple of years, I think we're seeing a huge growth because people are really realizing the potential impact and opportunity in terms of thinking about addressing health disparities in particular. So why does it matter? How did it come about? So what we've had historically is just a huge gap between research in terms of what we actually know works, what programs are evidence-based, what policies are evidence-based, what practices are evidence-based, and then practice and policy in terms of what's actually delivered and implemented in real-world community health systems and policy settings. And there's been a huge gap between research, practice, and policy that's been widely recognized and documented, and huge gaps in terms of the quality delivered as well. Huge gaps in terms of actually addressing social determinants of health. So because of this recognition, there's a huge report from the Institute of Medicine about almost 20 years ago now. And I think implementation science has really developed in response to that well-documented gap, really in an attempt to try and bring together what we actually know works with what's actually delivered. So this is an exciting time for the field. I think historically as researchers, when you think about kind of academia historically, what we've done is we've had a focus on getting research grants and then often publishing them, and kind of this assumption that if you build it, if you publish it, if you present at conferences, then that's enough. We've gotten our findings out there, and then somehow magically they'll actually get into the settings that need it. They'll get into the work sites or the health clinics or the community centers or the churches, and we'll have our health programming kind of magically delivered there. But the reality is, as many of you know who work in these settings, that doesn't magically happen. It's not enough just to, as a researcher, publish your research, publish your interventions, and hope that they actually get out there into the real world. But that's kind of been our approach historically in the field. So again, implementation science has really developed to try and address that and start to realize that we need to do more to actually make sure that we're getting the programs, we're getting the policies, we're getting the evidence-based practices in the hands of the communities and peoples and systems that actually need them. There's been this well-documented, what they often call the 17-year Odyssey. And this is just research that has suggested that it can take 17 years for us to actually get research translated, again, into real-world settings and into practice. And when you actually have been involved with this process, you start to understand this delays. By the time you apply for a grant, by the time it's reviewed, by the time it actually gets funded, and then you actually conduct the research and then publish it, you start to get a sense of why this takes so long. But again, implementation science is really about how can we accelerate this process. It's not okay to have a gap where what we know works takes almost 20 years to actually get delivered. So how can we think about accelerating this time period? And some people have called this the leaky funnel. So again, the idea here is that we know it's not enough just to create scientific discoveries and identify evidence-based program. Just publishing, just communicating about them broadly doesn't lead to actual uptake or adoption of the programs. Again, evidence is not enough, knowledge is not enough. We have to actually think about creating changes in the organization and the context to support evidence-based practice. There's also been some research that suggests that it takes, again, 17 years to turn only 14% of original research to the benefit of patient care. And that research has been in more clinical settings. And if you have done work like I have done in community settings or more low resource settings, a lot of my work has been in community centers and churches. The gap there in terms of the amount of time that we actually see the benefits sometimes of research is even greater. So again, there's an impetus, there's a need for us to think about how we accelerate this gap between research and practice. So again, this is where implementation science comes in. So implementation science is really about how do we move the needle and ensure, again, that evidence-based practices, policies, programs have an impact on population health and health inequities. It's really about what are the methods, what are the strategies, what are the approaches where we can proactively promote the adoption and the actual use and integration of evidence-based interventions and practices, again, in real-world clinical and public health settings, with the ultimate goal of improving kind of the quality of care when we think about public health. But when we're thinking about the work that we do more broadly in public health or in community settings, how are we improving and addressing social determinants of health as well, with a lens towards promoting health equity? So this is really what the field is all about. So there's been an important distinction, I think, between dissemination science and implementation science, which I'll just note. So dissemination is really focused on trying to understand factors and strategies to promote the widespread adoption of EBIs, or evidence-based interventions, among key stakeholders. So if you think about, let's say that you have an intervention in a community setting to address food insecurity, for example. This would be about how do you actually get that evidence-based program that's been found to work into the hands of the settings or the implementers who would actually need to deliver that nationally. And so that's really about how do we improve kind of the initial adoption or kind of uptake of the intervention. Whereas implementation science is kind of once you've already got the word out about the program or the practice, the key adopters or decision makers are on board. So if it's, for example, at a church setting, maybe it's the pastor who has agreed to adopt the program to address food insecurity. And then implementation science would be, okay, now that we have the key stakeholders on board, what are the factors and strategies that lead to the setting actually being able to integrate and use and deliver the evidence-based intervention within that specific context or setting? So it's about how do we embed these interventions in real-world, diverse settings and practices. So again, just so you have a sense from a research lens of how the language people are using to talk about this, because there is a lot of terminology in this field. So I just want to make sure that people are clear on this. So again, dissemination is about kind of that focused distribution of the intervention or information to a specific audience with the goal of kind of increasing widespread adoption of the program or practice. And again, implementation is about really, once you already have it disseminated either nationally or at a local level, how do we actually embed it? So it's not enough to say we have this program, this evidence-based program, the pastors are on board, we're ready to go. But then what needs to be in place? Is it having champions? Is it having a peer network or peer leader? Is it about having training or technical assistance? So then what actually needs to happen in order for it actually to be delivered? So that's an important distinction in the field. When we think about the type of research we do from an implementation science and how it's distinct from other types of research, I just want to make a couple distinctions as well. So, we've thought about different types of evidence, and a lot of our evidence in public health or in medicine has really been about, again, developing interventions or programs or practices that work. So, if we're thinking about reducing smoking, we might think about looking at taxation as a policy or approach, or a media campaign, or price increase. Implementation science is really about once you already know that something works, whether it's an intervention or practice or program or policy, and you really want to understand, again, what are all the contextual factors, what are all the strategies that need to be in place to make sure that this thing that we know actually works, again, actually gets delivered and actually gets put in place. So it's really about the how do we go about doing this? How do we get it implemented so that it can actually impact population health and health disparities? So when we think about potentially where, again, this research falls, a lot of research just generally has focused on testing, does a program work? Is it effective? Does it increase colorectal cancer screening? Does it reduce food insecurity? Does it promote physical activity among youth? And again, this work is moving towards, okay, we already know that this works. How do we actually get it embedded in our communities, in our neighborhoods, in our federally qualified health systems, in our churches, in our schools? So it's really about, again, the real world settings, the populations that actually need these programs that are effective. How do we make that happen? There's lots of, through these modules, there's going to be lots of areas that we tap into in different domains of implementation science. So again, I made that distinction between dissemination and implementation. There's a lot of work on thinking about adaptation of programs to fit new contexts or populations. There's a lot of work on thinking about how you select a program. And then there's some work I've done on sustainability. How do you actually sustain the program over time across settings where there might be lower resources in particular? So there's a lot of great work going on in the field, and we'll tap into some of these through the modules. The Patient-Centered Outcomes Research Institute, or PCORI, has also done some really great work thinking about the different phases of implementation science that I find useful. So, in the evidence assessment phase, you might be thinking about, what are the potential options we have for evidence-based programs? And do they respond to our community partners' needs or our stakeholders' concerns? Who are our key stakeholders we need to engage on this? Who can help us identify who the key adopters would be? Who would benefit from this evidence? What's the gap in terms of the health disparity issue or the health setting gap in terms of who's actually being reached? How can we disseminate this program? Who needs to be reached and what's the best way to reach them? How can we implement it? How can we support their actual widespread use and integration in a lasting and meaningful way? And then how can we evaluate this? So there's kind of been this work on dissemination where they're doing the dissemination, but then they're not learning from it. So implementation science, again, brings in the lens of what can we learn from and share so that we have best practices as a community, as a network, to improve this work over time. So what data would be meaningful to our stakeholders and partners to include, to inform this work? So again, why is this work needed? So as we've said, there's been this well-documented gap between, again, what actually we know works and then what's actually being delivered in real-world community settings. There's also been a lot of accountability. We have developed so many interventions. We've received so much funding as researchers. And I think there's starting to be questions from the public, from funders saying, okay, what's the actual impact of all these interventions we've developed? We're still seeing huge health disparities globally, domestically, and at the local neighborhood level. So what can we do? How can we use implementation science to start to think about addressing this? And I think, again, there's a lot of opportunities to create conditions to promote health equity through this work. And again, I think we have a wealth of knowledge, both from community partners and researchers, in thinking about how we work together to impact population health and address this implementation gap is a really important opportunity. As researchers, sometimes when you look kind of in public health in particular at the extent to which people have been disseminating interventions or programs, there was some work done a couple of years ago by Ross Brownson and colleagues, and they surveyed almost 300 public health researchers. And about a third of those researchers rated their own efforts on dissemination of their own work as poor. They found that if a researcher was disseminating their own work, they were more likely to have previous work in either a practice or policy context. And what they found is that 73% of researchers, so the majority, spent less than 10% of their time on dissemination. And I think part of this has just been the research context and funder accountability. Often researchers haven't had to have the accountability that they're actually doing something with their work. So if they find that an intervention is effective, historically it's just been enough to publish it and say, okay, on to the next thing. And again, now I think because there is more accountability and recognition that what are you actually doing with that work? How are you actually getting it in the hands of the people who need it? So there is greater focus on that accountability, which is really important. And I think there's growing recognition that we have to really think about how we're involving stakeholders in the research process and throughout of it. So my research in particular, that's really foundational. I work with my community partners to identify what the needs are and prioritize whatever gaps they want to address that are meaningful to them. And I think we're seeing a shift in research towards this kind of work, which is exciting. So that's another kind of fundamental part of implementation science.